Opsfeld. I'm an associate professor of clinical pathology and lab medicine at CHOP and Penn. Thank you all for joining us for our 2025-2026 Informatics Talk Series. This is a great opportunity for the CHOP community to come together to hear about informatics research happening across all areas at CHOP. Before we get started, just a few announcements. Next month, on April 23rd, we'll be hearing from Dr. Ji Wang. Dr. Wang is an assistant professor at Penn. His research focuses on AI and ML innovation and its application to medicine, with topics including vision language foundation models for pathology, human AI collaboration, and neurodivergent diseases. And we hope to see you all there. You can conveniently text to receive CME for this informatics talk. Please text DBHi 26 to 215-274-0239. That's 215-274-0239. You'll get a confirmation text if that is successful. And you can text this number anytime between now and 15 minutes after the presentation to receive credit. If this is your first time using Cloud CME, please follow the instructions posted in the chat. There will be a Q&A at the end of the presentation, and we ask that you use the hand raising feature to ask your question, or feel free to write your questions in the chat during the presentation. Also, please mute your microphones. You can turn on live captions by clicking the ellipsis on the top of your screens in the language and speech and live captions menus. And then finally, I am proud to introduce today's speaker, Dr. Narek Israelyan. Dr. Israelyan is a clinical informatics fellow here at CHOP and a clinical instructor of transfusion medicine at the University of Pennsylvania. He completed his medical training at Columbia University, followed by pathology residency and fellowship at the University of Pennsylvania. He is board certified in clinical pathology and blood bank and transfusion medicine. His work focuses on the integration of clinical informatics with lab medicine and transfusion medicine. Today, Dr. Israelyan will explore foundational lessons learned from completing real-world informatics projects during his fellowship. And without further ado, Dr. Narek Israelyan, please go ahead.
Great. Thank you, Amram, for that introduction. Let me go ahead and share my screen. All right, you all should be seeing my screen now. And again, thanks for the intro. My talk is pretty self-explanatory from the title. I'm going to be going through 3 projects that I have cherry-picked in order to illustrate some key lessons that I picked up over my 2-year clinical informatics fellowship. Here are some objectives for your CME credit today. The main purpose of the talk is to go over 6 lessons that will hopefully help other people as they're going through their own informatics projects. The projects that I mentioned will touch on a couple key areas in project implementation, including workflow analysis, user-centered design, human factors engineering, and post-implementation maintenance. Without further ado, here are the 3 project domains. I'm going to start with provider documentation first. This one is special to me because it was the very first project that I ever did, and it had some pretty good lessons in it. So before I jump into the project itself, here's a little background on what I do for a living. I get asked this question all the time, even from my colleagues in medicine. What does a transfusion medicine doc do? So one piece of my job is what we call apheresis. It's a Greek word. It means to remove or to take away. And the underlying concept is that we remove a patient's blood, separate it by centrifuge, and specific parts of that are kept while the rest of it is returned to the patients. There are 2 different categories of apheresis. One is therapeutic apheresis, in which we're removing something as part of a disease process. You could think of diseases like TTP, antibody-mediated organ rejection, sickle cell disease, where we're removing the agent that's causing disease. The second category is donor apheresis. And if you've ever been to a blood center, you may have donated red blood cells or platelets via apheresis. But in our apheresis unit, we perform primarily stem cell collections and mononuclear cell collections, which are mainly for T cells. At Penn, we have our own CAR T production facility called the CVPF. So For our software developer folks, this is a full stack process in which in our apheresis unit, we're collecting those T cells. The CVPF is actually manufacturing the CAR T product, and then we're reinfusing them in our apheresis center. So with all that said, we have a busy clinical service with 19 beds and between 10 and 20 patient encounters for the clinicians. And our clinical team generally consists of one resident and an attending, and occasionally a fellow as well. But really, the resident is the frontline person who runs the service. And as part of their job, they have to write notes on every patient that is seen. When I was a resident, we had a piece of paper taped to the wall in our resident room that had this list of smart phrases, which are also called dot phrases. These were, first of all, created by a previous resident, and they were stored in his Epic profile. So every time a new resident came onto the service, as part of their onboarding, they had to go in and add each of these templates into their own Epic profile so that they could use them. And then when you were on service, every time you saw a patient, you had to remember the specific dot phrase. You had to type it out correctly and start to fill it out. Hopefully you picked the right one. You didn't have to come back and erase it and start all over. So when I started to go through Epic training in the beginning of my informatics fellowship, I very quickly realized how much better the system could be from both an efficiency standpoint and a provider satisfaction standpoint. And it didn't take very long. It was actually the very first class I ever took, which was Notecraft. So for any of you who are watching this and may be interested in making some kind of change, like I'm going to show, this is a really low effort way to learn how to improve provider documentation. And the goal was pretty simple. It was take all of these manual dot phrases and convert them into simple, straightforward buttons at the top of the notes activity for quick access. Another goal was to make these available for the residents right away without them having to add anything to their profiles during onboarding. So we did that. And in addition to doing that, I also learned how to do some somewhat fancier things in the Epic class in order to take these notes to the next level. Our attendings were noticing that some important pieces of information like pre-medication or electrolyte repletion were getting missed sometimes in the notes. So as a reminder to the residents, we implemented these yellow optional sections, which disappear if they aren't filled out. And they're not always applicable, so sometimes they just won't be used. For certain note types, we use disappearing text, which you'll see at the bottom over here. And these are for additional reminders depending on the specific situation. And each of these notes had different reminders in them. We also played with the way that the lab values work on the back end. So if there was no lab value, then it would display a blank here instead of returning a text that says no result. So just cleaning up the text a little bit. So that was all fine and dandy, but we really want to see if there was an actual effect for making these changes. And one of the ways of doing that was through a tool called Epic Signal. And this is a proprietary Epic tool that essentially tracks how users interact with the system. It's not perfect, and there are certainly limitations to this, but there are a lot of potentially useful metrics if your goal is to see whether your project has any improvements in efficiency. Here are some metrics which you might find valuable. Many of them are time metrics, which can be confounded by idle time, but there are a lot of others too, like note length or number of messages received. There are dozens of these. So this is just a snapshot of them. And the one we chose to look at was time spent in notes. We use this metric, but we wanted it to be more standardized given that our patient volume can be drastically different on a daily basis. Thankfully, this was considered by Epic when they created this specific metric in Signal. And so the one they use is called time spent in notes per patient per day. So that helps to account for the patient volume on a daily basis. Again, the basis of this metric is that we're looking at the number of minutes that are spent in the notes activity or with the notes activity open. So when you're looking at this data, each of these dots here are going to be an individual resident. And that's because our residents are only rotating through our service once. So we weren't able to get any pre and post evals on the same resident. So each of the cohorts you're seeing on the left and right are completely different groups of people, which is a limitation to this. But regardless of that, we did see a significant decrease in the number of minutes that residents were spending in notes per patient from about 12 minutes to 9.5 per note. And if we do a little rough math on the opportunity cost here, it's about a $5,600 savings per resident per year. It's a soft ROI for sure, but it does give us evidence that what we did had not only an efficiency savings, but a financial component as well. And again, because of the issue with the residents rotating only once, we didn't do a subjective satisfaction survey. And so the new residents will never know what it was like before, and that's okay. And now the lesson learned from project number one. The first lesson, which has come up continuously in my time as a fellow, is that it is really all about the workflow. I was able to do this project so easily because I knew our workflows inside and out. I knew what mattered to our attendings. I knew the pain points for our residents because I was one myself. And this point especially resonates with me as someone with a background in path and lab medicine, because I don't have the same training experience as a lot of my colleagues who were trained in pediatrics or internal medicine or a surgical subspecialty. So now, as a clinical informaticist, it becomes doubly important for me to really understand a different services workflow. And so for my projects, I had to do very careful hands-on workflow observations, mapping the processes, creating flowcharts and swim lane diagrams. So this was a really important lesson for me. And lesson number two is to eat the low-hanging fruit. I am a huge fan of low-hanging fruit. I think they taste great. I found that doing this was especially useful for me in showing my value or the value of my work in a quick way. And I think this is especially applicable in informatics when we're trying to get funding or support for bigger projects. These quick wins that I did were really good ways of just gaining credibility, networking, demonstrating my skills. So if you're a trainee and you're looking to do these things, keep an eye out for these low-hanging fruits. All right, and that is project number one. I'm gonna pause for a second, look at the chat and see if there are any questions. If there are, you can raise your hand or come off of mute. Okay, so I'm gonna keep going. The second project here is in the realm of order build. And the first project I talked about was my very first one. This one is going to be the biggest one that I undertook during fellowship, and it was the most time consuming with the most moving parts. So going back to what I do as a transfusion medicine physician, the other big piece of our job is overseeing the hospital's blood bank from a medical director standpoint. Just like in apheresis, there's a divide between what the blood bank does. The first realm is diagnostic blood banking. So here we do things like blood typing in the top image. We do antibody screens. We do antibody panels, which are these Sudoku-looking puzzles, and they help us to identify what red cell antibodies that a patient may have. We also do cross matches where we mix a patient's serum with donor blood to make sure that they're compatible before we release that blood. And all of these things that we do in the blood bank are really to ensure the safety of the blood that's being administered. Everything in the blood bank really comes down to safety and compatibility. That's really the name of the game. Going one step further, in blood banking, there are a number of medical conditions that require us to modify the blood product that we're sending out to make them safer for the patient. And one example is leukocyte reduction, which does the three things that I've listed here on the screen. Leukoreduction now is performed essentially universally across the US, and this happens at the blood center before we even receive the units at the hospital. Another example of a modification is irradiation, which, unlike leukoreduction, is not generally universal depending on where you work. Irradiation reduces the risk of transfusion-associated graft versus host disease, which is a really rare adverse effect of transfusion, but it has a really high mortality rate of greater than 90%. At CHOP, we have a specific list of conditions which puts a patient at a higher risk of having this event. And therefore, we, as a policy, must irradiate blood that goes to these patients. Irradiation works by inactivating T cells, but there are some downsides to this in that it increases potassium leak in the product. It also shortens the shelf life of red cells. Because of that, there are certain populations that we don't necessarily want to give irradiated blood to in a pediatric setting, particularly in some forms of cardiac surgery. And one side note that I thought that my fellow informatics enthusiasts would find interesting, there's actually this sticker on blood products, which is sensitive to irradiation, actually. So initially, the sticker says that the product is not irradiated. Then when you hit it with the actual radiation, that turns black. So that's a safer way of knowing if your blood product has actually been irradiated. Pretty nifty feature. So at CHOP, our red cell inventory is mostly irradiated with a couple exceptions, and those exceptions are blood going to the OR and emergency release red cells. All that background in mind, there was a safety event that occurred regarding irradiation that really triggered the work that I'm going to talk about. So almost 2 years ago now, a 16-year-old male with ALL who was new to our system presented to the ED for a left femur fracture. They were admitted to Gen Peds, surgery was scheduled, and blood products were ordered. There were 4 different orders placed, and 3 of them did not have any indications for radiation written into the order. One of them had history of ALL typed into the comments, but it was missed by the blood bank technologists. The patient then went to the OR where they received 2 units of non-irradiated blood. About a week and a half later, this was caught when additional blood was ordered when the patient was back on the floor. The blood bank medical director was notified of this and got involved. Thankfully, the patient did not have any signs of TAGVHD, but it was a near miss event. So what happened? This is actually the way that I stumbled onto this project as a fellow. I was a spectator at the CHOP Clinical Decision Support Committee meeting when this safety event was presented to the group. Initially, what was asked by the group was to just add another question here that would address the patients who have hematologic malignancies because it didn't actually exist in this order. Instead of just approving that simple addition, the CDS committee said, hey, I think there's actually a problem with this whole order. We recommend that you meet with a bunch of different people and really think about how to improve this and how to fix it. They gave some suggestions on what to do instead of just adding another defaulted question. And at this point, I reached out to the presenter and I said, this is right up my alley. Can I get involved in this? And so from then, what we did was we took this project to our larger multidisciplinary transfusion committee at CHOP for initial review. This group gets representation from hematology, nursing, critical care and anesthesia, quality and safety folks. And from that larger group, we then formed a smaller group who worked directly on these changes and met at a regular cadence. And I was the primary builder for this project. As far as frameworks go, we used a spiral model of iteration and reiteration. We had monthly meetings over the course of a year until this finally went live. And that brings me to one of the huge strengths of the clinical informatics fellowship training that I did here at CHOP and Penn, and that is the sheer number of experts that we have on faculty here. So as an informatics fellow over our 2 years in the program, just like other clinical programs, we go through different areas of informatics in formal rotations that are led by people who have expertise in those areas. And when you're on these rotations, the expectation is that you do a project within that realm of informatics. You can start a new project at the beginning, or you can bring one that you've been doing previously. And for this project, since I was working on it for such a long time, I had the pleasure of discussing it to various degrees with the many different folks that you see here on the screen who are in charge of these rotations. And I think that that put me in a very unique position to get a lot of ideas and different viewpoints that I may not have had otherwise. So here's a closer look at the original order. You can see a long list of questions that have defaults already pre-selected. Only a few things are calling your attention, and these are the red exclamation points. But you can see how some of these questions that we find in the blood bank to be very important can be very easily glanced over and missed. If you're just opening this order, you want to just order 1 unit of blood and you don't really care what else is on here. Fast forwarding a little bit to the end, this is the final state that is live now at CHOP. So I'm going to go through the relevant pieces of this order one by one and talk about them individually. To be clear, I'm only going to show the changes we did for the red blood cell order. The project involved updating all blood product orders and all the relevant order sets, but the changes I'm going to go through are similar to what we did on the other orders. And this is piece number one. This is the portion that's at the very top of that order, and you have to look very, very carefully to see what's different between them. You see it? Yeah, there's nothing different between them. And that was very intentional, specifically regarding this piece over here. Is the type and screen needed? We went through a lot of discussion trying to determine how we could improve this. What is the purpose of this question? What do we gain from it being answered? What do we even do with that answer in the blood bank? Can we automate this? Could we make it so clinicians don't have to waste their time answering it? How can we actually improve this? And the more we kept digging into this, we found more questions and more potential confounders, which would make our build particularly difficult to do and ultimately not very safe. Which brings me to lesson number 3, which is the juice worth the squeeze? You know, we thought to ourselves in this situation, could we safely make a change? And are the hours that we're going to spend to change this, are they going to make a meaningful impact? And the answer ultimately was no. And so we decided that in this case, for this question, the juice was not worth the squeeze. The next piece of the order is level of urgency. This question had a lot going on. You know, you might not be able to tell from looking at it right here, but there really was. The word preoperative, first of all, is not a level of urgency, but it fell into this question. And it's a little confusing. Does preoperative mean that we're ordering this for transfusion in the OR? Does it mean that we're ordering this for transfusion on the floor before a surgery? It just wasn't clear. And also, what does routine versus urgent versus stat mean? How is that going to change when I receive my blood if I'm a clinical provider? So to address this, we did a couple things. First of all, we separated the questions into 2 different questions. We added some more decision support directly into the line for the level of urgency to tell providers when they should expect to receive the blood based on the selection that we're making. We also created a more precise question to clarify that preoperative situation, which then could be defaulted to yes, for example, if you're creating this order from a pre-procedure anesthesia order set. This question involved a lot of work and wordsmithing, particularly because this is a unique situation in which the front end user-facing order is then actually used by another human being on the back end when this order prints out in the blood bank. So we needed to make sure that the language we were using was appropriate for the blood bank technologists to see it and understand what they need to do with that unit of blood when this piece of paper then prints out in the blood bank after a user puts in the order in the EHR. Next up, and one of the first goals of this project was really looking at that long list of diagnoses that we're asking about. Instead of adding an additional question, we instead decided to combine all of these into one question. We also made the decision that this is important enough that we really want the provider to stop and make a conscious decision about the diagnosis in the order set, given the risk of a bad outcome if it's missed. We tried to be as clear as possible in the question stem to let the provider know why we're asking about this in the first place, not just, hey, does this patient have a bone marrow organ transplant? We're specifically asking because we may need to modify the blood product based on the answer that's given. And this was really the main way we addressed that initial safety concern. From our discussions with human factors, we were able to come up with this next fix to declutter the order and reduce cognitive burden during the order process. So in our original blood product order, we asked 3 questions regarding directed donors and autologous donors. This is a very, very rare occurrence at CHOP, but it was taking up 3 whole questions in our initial order. So instead, we consolidated 2 of those questions into 1 question, and then we incorporated branching logic. So if the provider changed the answer to yes here, the patient does need directed autologous units, then and only then do they see the next question. And lastly, the final piece of the order has to do with babies. In the original order at the bottom, we ask about birth weight because low birth weight infants are at higher risk of TAGVHD and should get irradiated blood. First point is that this question appeared for everyone, regardless of the age of the patient. Then, more importantly, the question requires that the provider navigates away from the order, goes into the birth history, finds the weight for the patient, comes back and enters it in this box, all while keeping that birth weight in their head. And we thought we could do better. So instead, we built a question that first and foremost appears only if a patient is below a certain age. And for the purposes of this, we chose 6 months. I can get into some of that if people have questions, but the question then more plainly asks if this is a neonate with a birth weight less than 1.2 kilograms, which is really the point of the question, not what's the birth weight. It is the birth weight less than 1.2 kilograms, which would trigger us to irradiate. And now, instead of making the provider navigate away, we built a rule in which that question would automatically answer itself based on the existing birth weight that we have in the chart. Then, to give more confidence that the answer was correct, we actually added a section that displays the baby's birth weight below it in kilograms. We built some other, guardrails. If there was no birth weight that was documented in the chart, the question was left unanswered and was required for the provider to answer it. So those were the main changes to the red cell order itself. Now, to understand how providers felt about these changes, we created a usability survey in REDCap. This survey displayed both orders to each user, and it walked them through the features of each order using a series of, I believe, 6 different screenshots. And then at the end of each order, it asked questions about how the user felt about the order. We tried to avoid bias by not labeling the orders as this one is old, the old order, this one's the new older order. We just labeled them as order 1 and order number 2. We also randomized this to try and prevent further bias. So half of the folks were presented with one order first, and the other half was presented with the other order first. We had 83 total users to complete the survey. About half of the providers were trainees, a quarter of them were APPs, another quarter were attendings. The strongest representation department-wise was from general peds, followed by crit care, neonatology, hemonc, and 1 cardiology provider. There was a pretty even split between how often providers order blood, with one standout champion here who orders blood on a daily basis. Thank you so much for keeping us in business. You are really our champion. And so now this is a screenshot of the questionnaire that the users were shown after each order. There are 5 questions here with a Likert scale ranging from strongly disagree to strongly agree. Each of the questions actually alternate in terms of positive and negative wording. And that was just to prevent someone from just selecting one thing all the way down the row and really making them read the questions and slow down. Based on the answers to these results, we adapted the well-known system usability score, and we made some adjustments to account for the fact that we only had 5 questions. And the results here showed an improved usability score between the old and new orders with a difference of about 10 points in the SUS score. At the end of the survey, we had a free text section. About a little over half of the providers wrote comments, and 16 of those comments are what we categorize as constructive and either suggested additional improvements or new things that they want to change or said what they really, really did not like about what we did. And all these comments were very helpful for us in our iterative process. There were several things that we simply couldn't do anything about because they were epic limitations. And at the moment that we were doing this build, there was nothing we could do about it. Or they happened to be things that we purposefully did for safety reasons. But regardless of all that, it was really important for us to know what these pain points were for the actual people who are using this order the most frequently. And that brings me to lesson number 4. Listen to the curmudgeons. So I love being told what I'm doing right naturally, but the most important feedback in my eyes, especially when it comes to a computerized workflow, comes from the cranky comments, if you can call them that. Negative feedback has been very welcome during my process as an informatics fellow and has really been an essential part of all my projects throughout fellowships. I actively seek it out. One of the bigger outcomes from the feedback that we received and from the additional feedback I got after representing this to the CDS committee was the introduction of this new sidebar. When we created this, we actually had an Epic Foundation sidebar that we then customized to meet our needs and our specific use case at CHOP. For the consent section up here, we realized that consents can either be electronic or manual, so we really needed to represent both of these modalities. So that required a change from the Epic Foundation report. For the last lab section, we modified these slightly to fit the needs of each blood product order and what is important when you're ordering that product. And then lastly, the irradiation information section, that was an additional thing that was added that helped to address some of the main causes of this safety event that happened, and it had some links for providers in case they wanted more information. Is there a question? No. Okay, so ultimately, what we did was we updated 20 different orders, including all the blood products you see on the right here, and their specific counterparts when you're ordering in a weight-based ml dosing instead of in units. Another thing we did, which was feedback from the RedCap survey, was that we updated all the transfuse orders as well, in addition to the prepare orders. After all this was done, we realized that there were dozens of order sets that utilize these orders on a regular basis. So we had to go back into each of these order sets and update them to make sure that they were using the current order and not the old one. This went live in October of last year. And finally, again, based on those curmudgeon comments I showed you before, we got our next big project, which is underway now. We are updating the type and screen order as part of an initiative to reduce unnecessary and duplicate type and screens. So stay tuned for those changes. And that is project number 2. I'm going to take a quick pause again here for any questions and take a look at the chat.
And Eric, there's a question in the chat come from Gerard Hills. I can read it for you. For the diagnosis block, did you consider pulling some of the diagnosis data from the chart? Some probably could be pre-populated, but confirmed by the provider in the checkbox format.
Yeah, that's a fantastic question. And that is one of the first things that we wanted to tackle. So, and I'll go back to showing that piece. Here we go. Yeah, so we really did think about trying to automate some of this based on stuff that exists in the chart. That was one thing that we considered. The other thing we considered was if a provider answers this question, should we keep that answer throughout that patient encounter to make it easier on the provider moving forward? We ultimately decided to not do either of those things. And the reasons are because first of all, we think that the biggest issue and the biggest safety concern for this are patients who are new to our system. When they're new to our system, there's a good chance that that data does not exist in the chart. That's number one. Number two is that if this question is answered by default, the provider might miss an additional diagnosis that would require us to do a different blood product modification. So, for example, if the patient has a history of cancer, but they also have a hemoglobinopathy, if one of those are recorded as, in the problem list and it auto-populates here, there's a chance that the provider will not look at this question and miss sickle cell disease, and then we don't end up doing the specific modifications we need for sickle cell disease. For the second part of that, we chose not to keep the answer within the same encounter on the off chance that someone either incorrectly selects none. We don't want that none to persist throughout that encounter. And as far as we know, there was no way to basically hone this in on only the none selection. If there was a way where if a provider selected none, the next time it shows the question at default, we would have moved forward with that, but we didn't find a way to actually do that in the system. The other concern would be if there was a new diagnosis during the hospitalization, but initially none was selected, for example, and then they went to order blood products and missed that. Someone may misplacing a distant diagnosis. Yeah, absolutely. Okay. Well, on to the last project that I have, which is in the realm of interruptive alerts. And this is a project that I started during my ED and acute care informatics rotation, working with Joe Zork. And now we are in the post-implementation maintenance phase of this project. And this is the last episode of What Do I Do? And this one is really what my primary professional interest is, and that's patient blood management. PBM, as we call it, is a three-pillar approach to essentially keeping the patient's blood inside their own body. There was an urgent policy brief by the WHO in 2021 after the COVID pandemic, which urged hospitals to implement these programs. There are multiple components of this, and the three main pillars are one, early diagnosis and treatment of anemia, which usually refers to a preoperative setting, diagnosis of preoperative anemia. Number two is minimizing blood loss, which is generally in an intraoperative setting, and avoiding unnecessary transfusion, which really is everything else. And I believe that this is an area that is ripe for informatics involvement, which is perfect for me. For anemia detection, we can think about predictive modeling to aid in diagnoses. We can do performance measurement by creating analytics to evaluate the order appropriateness based on lab values. We can create dashboards to give clinicians feedback and compare them to their peers. And for standardization of care, one piece of this can be alerts that pop up when transfusions are ordered outside of established guidelines. And that's really what this next project is about. It's standardization. One big problem in the face of PBM is that there is such high clinical variability in how providers order blood products. And this just comes with the territory, with all the different services that are ordering blood, all the different indications for these orders, and the fact that there really aren't clear guidelines for every situation. The vast majority of clinical trials that have been done for transfusions are for red blood cells, and they're for very specific situations. However, for the areas that we do have guidelines for, we can utilize these guidelines to create real-time clinical decision support tools that we can then embed into provider workflows. One additional issue with these existing guidelines that we have is their complexity. Now, what you're seeing on the screen now is an established guideline based on a series of trials in the past 10 years. And this specifically is for transfusion of red blood cells in the pediatric ICU. So a pretty narrow use case. Despite that, look at the complexity here, especially when you have a patient with a hemoglobin greater than 7, making the right decision here is very complex. Because of that complexity, I think this makes sense for us to utilize discrete data in the patient's chart to help the provider make a decision in this scenario. So that's what was done. What you're seeing here is an alert that went live in the CHOP PICU and the CICU a couple of years ago before I had started as a fellow. And this was primarily done because of supply chain reasons. The COVID pandemic did a number on the blood supply. And because for this situation, there were established guidelines, there was an opportunity to improve that supply chain issue. So the complex pathway that I showed you was then converted into a number of different criteria records in Epic. And then when you go to order a unit of blood that's outside these criteria and the guidelines, you get this alert here on the right. You're able to remove the order directly in the alert. And if you decide to keep the order, you had to acknowledge why you were doing so. After I joined the project, we wanted to look back and see how that alert had performed clinically. Did it make any impact on our blood transfusion practices when we're looking at hemoglobin levels? And one of the most common ways of evaluating this is through a tiered system, which is hemoglobin transfusions at a threshold below 7, in this intermediate gray area between 7 and 9, and greater than 9 grams per deciliter. We saw that after this alert was alive for several years, the proportion of transfusions at hemoglobins less than 7 increased by 5%. And conversely, those transfusions in that gray area of 7 to 9 decreased by 5%. The transfusions for hemoglobins greater than 9 stayed stable. And we think that this had a lot to do with situations like massive bleeds or things like priming the patient or the machine before dialysis or apheresis, where the hemoglobin level in the chart does not accurately reflect the patient's clinical status. And that point in itself is actually a whole nother problem for our clinical decision support tool. We then looked at how the alert itself was performing. And what we found was actually a very, very low rate of providers doing the action we wanted them to in the alert. And that was to remove the order from the alert itself. So this is pretty tricky. If we take just this piece of data on its own, we could think that our alert is failing. We're not having providers do what we want them to do within the alert. But as I went through this project, I discovered there's a lot more nuance than that. Perhaps the provider needs a second to think about it. Perhaps they're not comfortable having the alert do that action for them, and they want to review the order themselves. So to take this one step further, we wanted to look more downstream at our clinical endpoint, which is whether the provider actually transfused the unit of blood after they saw this alert. And that's exactly the premise of this next piece of data. So this chart is evaluating the number of alerts that were then associated with a blood product order within 6 hours of that alert firing. And so despite that very low compliance that we're seeing with the alert button, 19% of users who saw this alert actually did not proceed with ordering a blood product within the next 6 hours. And that brings me to lesson number 5, which is one of my favorites. Ball don't lie. Those of you in the audience who are NBA fans may recognize this. For those who are not basketball fans, the phrase ball don't lie was coined by this player, Rasheed Wallace. When a referee would make a questionable foul call, the opposing player would then go to the free throw line, When that player missed the free throw, he would yell, "Ball don't lie." And the thought behind this is that the objective reality or the ball would always reveal the truth. And to me, as an informaticist, I think our job is really to look at the ball in all different ways. And in this case, in this project, it means to look deep enough at what really matters, going beyond just that base performance of the alert, going downstream to your clinical outcomes is an example of that. So what did we do next? Now, like I mentioned, when I was on my EDQ care rotation, Dr. Zork approached me with this project. A group at Stanford was working on an enhanced version of the PICU alert as part of a large multi-center study. They wanted to evaluate the efficacy of an alert like this in making changes to provider behavior and their ordering preferences. Our PICU docs had worked with them and had an IRB and had agreed to include CHOP as one of the sites for this implementation and this research project. And this is what the multi-step alert looks like. So, you first end up getting the screen on the left if your patient initially does not meet criteria. Then, depending on your answer to that first question, you may get screen number 2 over here, which asks more questions about their clinical status. Is there a trajectory worsening? Is it stable, et cetera? And this is something that is a little bit harder to do on the back end in our current state with discrete data in Epic. Based on your answers here, there's a calculator on the back end that then tells you whether you are okay to transfuse, whether you should defer the decision, or whether you should not transfuse based on the clinical guidelines. As appropriate, this came back to my favorite committee at CHOP, which is the CDS committee. And there were a lot of thoughts about this alert. It is clearly a very complicated alert with multiple different inputs that we're asking providers to spend their time doing. And ultimately, what this came down to was that this was going to be a balance between what we want our CDS to look like at CHOP based on our institutional guidelines and the goals of this funded research project that CHOP had agreed to take part in. So we agreed to move forward, and the process for this project was somewhat similar to the previous one. Based on suggestions and networking from the CDS committee, we formed an interdisciplinary group of folks to discuss the alert, and we had our smaller group to actually do the design and the build. This project instead followed more of a waterfall model rather than a spiral because we had an existing alert to work with, and we needed to make some tweaks to make it appropriate for our patient population at CHOP. We did look at tools like Epic's Turbocharger, but it wasn't a quick plug and play like we had hoped. There were many things that needed to be altered to fit our system at CHOP, including the different lab tests, their different names, the fact that we have different point of care devices here, and the fact that we do a lot of dialysis and apheresis, for example. One benefit of having the prior alert live in our system is that we were able to review all of the feedback from this alert over the past 3 years. And it gave us a very important look into how to tweak our build to make it fit better for us. The 2 most common comments were that, number 1, actually, this patient's hemoglobin is less than 7 and your alert is not firing appropriately, so please address that. And number 2 was that, hey, this unit is being used as a blood prime for either dialysis or apheresis, so this is not appropriate for our situation. And we used a lot of these alerts to tweak and fix our alert before it went live. The alert went live in our system 4 months ago after a lot of prep work and discussions. Since then, we've been doing monthly reviews of the alert data with our internal group, which consists of our PICU leaders and our informatics leads. One of the important pieces of data we're reviewing, like the previous alert, we are looking at alert performance through what we're calling recommendation adherence. And this is essentially whether the recommendation that we made was followed in the alert. And if it wasn't followed, what were the primary reasons that the users selected for that? Our adherence rates that you see on the left here are just slightly higher than the previous alert that I showed you. In addition to doing that, we have been doing monthly follow-up for the non-adherent transfusions. From the informatics end, we generate this report every month that goes out to our 4 PICU leaders, and they've been taking turns looking into each of these charts one by one to evaluate further the real underlying reasons as to why they were non-adherent and whether that was an appropriate non-adherence or not. And it's been helping us to identify any future patterns that we can address or things we can tweak from an alert standpoint to make it perform better. Lastly, we've been coming up with some more downstream clinical outcomes to look at, and we're working to standardize these reports with what Stanford is coming up with to show their internal teams. And so here we have 2 SBC charts that look at pre-transfusion hemoglobin levels as an overall view, and another one looking at number of transfusions in the PICU, which are standardized to patient days to account for the patient volume. And with all that said, we come to the final lesson, which is that the go live of a project is really just the beginning, especially when it comes to interruptive alerts. No matter how you look at it, we are actively burdening our frontline providers by having them pause and take another action. So it's particularly important for these that they're evaluated on a regular basis and not neglected after they go live in the system. And here's a list of all the lessons from today. I'm going to be carrying this with me forward to my new job at St. Luke's University Health Network. I see a couple of folks on the call from there. I'll be starting there in July in a dual role as the network director of transfusion medicine and clinical informaticist. And I have a feeling that this list here is going to grow immensely. Lastly, there's a long, long list of people to thank. I want to highlight 2 of my primary mentors, Amram Absfeld, Jenna Reese, who've been guiding me on all of these projects, including the ones that I didn't mention today. Tony Luberti, who's been a fantastic program director and advocate, along with the rest of the fellowship core faculty, all the folks here who have contributed to all the projects I showed. So thank you, everyone, and I'm happy to take questions.
Okay. Congrats on that amazing work. Please raise your hand or put your questions in the chat, and I'll be happy to bring them to Narek. And welcome to our St. Luke's friends. Didn't realize that we had some guests here. And we have a question, I think, from Asif in the chat. I'll read it to you. He's saying that it's informative to see behind the scenes on the workflows to add CDS logic for patient safety and operations. The question is, once CHOP has effective generalized CDS, how are these shared with other organizations to not reinvent the wheel and or communicated back to Epic and incorporate this into their standard Epic builds? Great question.
Yeah, that's a really, really good question. And we came to this when we were trying to adapt the Stanford alert into our system. It would be fantastic if we could have like a base alert that Epic could then send out to all these different institutions. But what we found through this project is that there are so many nuances to each institution with the way that their records are built that it's a very difficult thing to do in a plug and play sort of manner. So, I think we can certainly publish, and I know that this project is definitely going to be published. And a lot of the things that we incorporated into this project were from previously published alerts over the past 10 years on this. So, but I think if there was a way to make this more plug and play to different institutions based on their records, that would be a huge, huge improvement.
Yeah, that's awesome. You mentioned on one of the slides, and I'm not super familiar with this feature, but the turbocharger mechanism. Oh, and Gerard is bringing up Galaxy as well. Those I think are mechanisms as well. I'm not super familiar with those with the process.
Yeah, yeah. So the turbocharger is really It's Epic proprietary, and it's basically a way of taking records from another Epic institution and, like I said, I keep saying plug and play, but putting it into your institution. We initially tried that, but it required a lot of tweaking. Galaxy is nice, and I used Galaxy a lot, especially when I'm looking to see what other institutions have done. So that could be another place, but it's more like a forum type of place where you go and you do a quick search and something pops up, and hopefully it's helpful for you. But I think those are pretty good tools in the toolbox to have.
Yeah, absolutely. I'm kind of oh, we have a question from Gerard, or at least a comment. Go ahead.
Fantastic talk. I was I was over here like having a fit, just excited about all the great things that you were doing, and obviously the overlap. I'm in hematology as well in informatics, and so running into a lot of the similar problems that you mentioned here today. And looking nationally, you kind of alluded to this. I noticed that many different healthcare systems are documenting and keeping up with their transfusion data very differently. For example, even taking a look across like other national systems, similar like to Cerner and Epic, I can see that like transfusion patterns for even subsets of patients, like those with sickle cell disease or thalassemia or other, are just varied. And sometimes it's not necessarily that a patient isn't getting like packed red blood cells, but it's just like what they called that order or whatever like they like denoted it to be in these different locales. And I don't know if you like have thought about ways that folks have been able to try to get around that, or if you've heard from your end, people, trying to come together and develop some level of like ontology to help like mitigate this issue.
Yeah, that's a great point. And I think one of the problems is that it's not that we don't have standards, it's that the different institutions are using them slightly differently. And when it comes to blood products, you know, when we do one modification on a blood product, it has a different name and a different code. And so that makes it pretty difficult. You could have an institution that has decided to just use the plain overarching red blood cell code, whereas another institution uses the very specific code where this product has been leukoreduced and irradiated and is hemoglobin S negative, etc. And so that makes things a little difficult. But I do think ultimately the answer would be in standardization. It's just really a matter of what group is going to come together to do that standardization. Is that standard going to be widely adopted, or is it just going to be one more standard that we have to think about incorporating? But yeah, it's a great point.
We are at the top of the hour, so I don't want to keep people unnecessarily, or keep Narek from the next thing he needs to do. I really want to thank you for sharing your experience and expertise with all of us. You've really shown, I think, the value of what our clinical informatics fellows bring to this institution. I think that from a patient safety perspective, like we all thank you for this work that you've done, and we're all very jealous of St. Luke's for allowing you to go over there. But best of luck with that.
Great. Thanks very much. Bye all.